Good evening. This is again Professor Nick Nikolov or PA Nikolov, Professor Triple N. Today is Thursday, April 7th, 2022, about 8:40 p.m. We'll discuss here is, I want, once again, if you have any question or suggestion, please free to send me an email to my email, which is very simple, NICK, like my first name, md1@gmail.com. In this chapter or lecture, we'll discuss fungal, tropical, and animal-borne disorders. Let's start with the fungal disorders. Dimorphic fungi are those which exist as a spore at a colder temperature and near like 20 degrees Celsius or 68 degrees Fahrenheit, but transforming into yeast in a warm 37 degrees Celsius or 98.6 Fahrenheit and moist environment of the body. Examples for this are coccidioidomycosis, histoplasmosis, cryptococcoidosis, and blastomycosis. All of these enter the body primarily by inhalation, by inhaled spores. Most of the infected patients are asymptomatic, but in the beginning, but when the symptoms occur, patients feel that they were having only a mild viral syndrome, which presents as a cough, headache, fever, arthralgia, myalgia, and also could be presenting as a self-limited pneumonia. Chest X-ray is frequently abnormal in symptomatic patients. In most of the cases, the symptoms resolve spontaneously. In a small number, but particularly immunocompromised or HIV positive patients, the dissemination of is noted of the infection could be to brain, skin, and bones. The best sensitive and specific test, this is a culture on a fungal media. For example, cryptococcosis and histoplasmosis can be detected by the antigen detection methods, and they're very fast. Let's go to the next slide. This slide discussed that mostly of the cases, they don't need treatment. Mild to moderate disease can be treated with antifungal medications such as fluconazole. More severe diseases such as meningitis are treated with amphotericin. And in the following slide, we'll have some highlights of these diseases. For example, coccidioidomycosis. The spore of this disease is very common in hot, dry areas, such as deserts, and sometimes they call it valley fever. The clue for diagnosis, this is a joint pain or so-called desert arthritis or desert rheumatism. This is a very common, and another clues for diagnosis, this is erythema nodosum. The most accurate test, this is a sputum culture and then serology. The treatment, of course, is two ways. For moderate and mild disease, we need to give a fluconazole or intraconazole. For severe disease, amphotericin. So-called exenocardins, such as caspofungin, are not effective. Please keep in mind. The next disease, this is histoplasmosis. The histoplasma fungi is found in a moist soil containing bird or bat fishes, for example, caves, river valleys, and so on. The disease can resemble TB in the lungs cavities. Anything TB can do, histo can do. Remember this clinical tip. Also, involve the bone marrow. It causes so-called pancytopenia, as well as spleen. And let's go to the next slide. Slide number 3. And lymph nodes. The most accurate test for this is culture of sputum, blood, or affected organs. And the urine and serum antigen are highly specific. The treatment, severe illness, gets amphotericin, followed by oral intraconazole, which is superior to fluconazole. Next disease, this is blastomycosis. Blastomyces fungi are found in the soil and rotten wood near water. Besides the lungs, can involve bone, skin, and prostate. Culture is determined. No serum or urine antigen tested. The question will describe budding yeast found in smear, and the treatment is, in this case, is intraconazole. In rare cases, severe cases, we need to use amphotericin. Next disease, this is so-called zygomycosis or mucormycosis. This is a mold which occurs exclusively in immunocompromised patients, especially diabetics with DKA. Deferoxamine increases the risk of mucormycosis by mobilizing the iron. Mucormycosis is hard to grow in culture and can be seen on biopsy. The organism rapidly dissects the nasal canal and eyes on through to the brain. Mortality is very high. Mucormycosis is a surgical emergency. You must quickly resect the necrotic areas. There is only one of the few. This is the only one of the few indications to use amphotericin as a best initial therapy. If the patient survives, needs to have a therapy with posaconazole and isavuconazole. Next disease, this is invasive aspergillosis. Invasive aspergillosis, although allergic bronchopulmonary aspergillosis can occur in a relatively, let's go to the next slide, number 4, normal host. Invasive disease occur exclusively in severe immunocompromised patients, most frequently patients with neutropenia and leukemia. The invasive aspergillosis progresses rapidly with lung infiltrate, which are visualized on X-ray or CT. There is a three non-invasive test for invasive aspergillosis: serum galactomannan, beta-D glucan level, and PCR. If any two of those are positive, there is more than 95% that this is the disease. Because of the sputum testing lacks sensitivity, however, diagnosis often needs to be done by lung biopsy. The best initial therapy is with voriconazole, isovuconazole, and capsofungin. Amphotericin is inferior to these medications and is the most common wrong answer. Next is tropical disease. Let's start with, so we're on slide 4, number 4, and we're discussing tropical disease. Malaria is a mosquito-borne disease presenting with fever, headaches, fatigue, and hemolysis. Diagnosis done by a tick smear for detection and thin smear for specification. The treatment for mild and moderate malaria is infection with Plasmodium falciparum, and treated with mefloquine or atovaquone proguanil. Wow, so hard to pronounce. The test is G6PD before using primaquine. Then the non-falciparum infection, we give chloroquine, or for Vivax and Oval only, we give primaquine. If we have manifestation of severe malaria, it means parasitemia more than 5% with CNS abnormality, such as confusion, seizures. Let's go to slide number 5. In coma, also hypotension and shock or pulmonary edema, also renal injury, acidosis, or hypoglycemia. Then we treat this severe malaria with artemisins such as artesunate and artemether. Also IV quinine has less efficiency and prolong the QT interval. For malaria prophylaxis, we use mefloquine and or atovaquone proguanil. We need to avoid mefloquine in patients who have history of neuropsychiatric illness. Down the slide, we need to talk about so-called mosquito-transmitted viral syndromes. While many mosquito-transmitted viral syndromes exist, only few are tested on the boars. The likelihood of testing is based on the likelihood that the syndrome will be brought to United States by traveler, tourists, or immigrants. So Zika, dengue, chikungunya are transmitted by Aedes mosquitoes. Ebola is not transmitted by mosquito. All of them cause fever, headaches, and malaise. All of them are diagnosed by serology by ELISA or PCR. None has a specific antiviral therapy or effective vaccine. There will be differences between these viruses. To answer a single question, what is the most likely diagnosis? For example, chikungunya is caused by a single-stranded RNA virus of African origin. The disease is characterized with intense joint pain and may persist for months, periarticular edema and rash, less than 50% of the cases. Dengue, let's go to the next slide. Slide number 6, which is the last slide. Dengue disease is characterized by bone pain, not joint pain, and the second episode is worse. The disease causes severe thrombocytopenia, which can lead to petechial and GI bleeding, and sometimes fatal hemorrhage and shock. We'll see a low WBC count and high transaminase. Fluids with blood and platelet transmission may be needed. Next is Zika disease. For the viral syndrome, Zika is the most dangerous in pregnancy because it can cause microcephaly, or can be associated also with Guillain-Barré syndrome. Ebola is not transmitted by mosquito or is not airborne. It is transmitted only by direct contact with body fluids from a person which has the symptoms. It presents as a non-specific viral syndrome, followed by severe GI distress and high volume diarrhea. Low WBCs and thrombocytopenia and increased transaminase are common features of Ebola. Patients often develop encephalitis before succumbing to hypovolemic shock and death. And this is the end of the lecture. Thank you so much for your attention. And if you have any questions or suggestions, please feel free to email me. My email is very simple, nickmd1@gmail.com. Have a good night.